Colon cancer staging, classification systems and clinical significance. Colon cancer staging determines disease extent and guides treatment planning. The TNM system evaluates tumor size, lymph node involvement, and metastasis to assign stages 1 to 4, directly influencing prognosis and therapeutic decisions. Understanding cancer staging in colon cancer. Cancer staging represents a fundamental component of oncological practice that systematically evaluates the anatomical extent of disease at the time of diagnosis. This process involves comprehensive assessment of multiple factors that collectively determine how advanced a malignancy has become. For patients with colon cancer, accurate staging serves as a cornerstone for treatment planning, prognostic estimation, and communication between healthcare providers. The staging determination influences virtually every aspect of subsequent clinical management, from surgical approach to systemic chemotherapy decisions and follow-up surveillance protocols. The TNM classification system explained. The TNM system represents the internationally recognized framework for cancer staging and has become the standard approach across most oncological specialties. The acronym TNM stands for 3 distinct components that work together to characterize the disease burden. The T component evaluates the primary tumor characteristics, specifically the depth of invasion through the intestinal wall layers and extension into surrounding structures. The N component assesses regional lymph node involvement, counting both the number of affected nodes and their anatomical location relative to the primary tumor. The M component determines whether metastatic disease has developed, indicating spread to distant organs such as the liver, lungs, peritoneum, or other distant sites. Together, these 3 variables create a comprehensive snapshot of disease extent. Tumor, T, component assessment. Evaluation of the primary tumor involves determining the depth of invasion through the colon wall and any extension beyond its confines. T1 tumors remain confined within the submucosa layer, representing early lesions with limited wall penetration. T2 lesions extend into the muscularis propria, the muscular layer responsible for intestinal peristalsis, but do not breach this layer. T3 tumors penetrate through the muscularis propria and into the subserosa or pericolic tissues, representing deeper invasion. T4 tumors demonstrate the most aggressive local behavior, either invading through the peritoneal surface, T4A, or directly infiltrating adjacent organs or structures, T4B. The depth of invasion correlates strongly with lymphatic invasion potential and regional spread, making accurate T staging critical for treatment planning. Lymph node N, component and regional spread. Regional lymph node involvement represents a crucial prognostic indicator and staging determinant. N0 classification indicates the complete absence of regional lymph node metastases, representing a favorable finding. N1 classification encompasses cases with limited regional nodal involvement, specifically 1 to 3 positive lymph nodes, N1A, or tumor deposits in the pericolic or perirectal tissues without recognized lymph node metastases, N1C. N2 classification indicates more extensive regional spread, with 4 or more positive lymph nodes, N2A, or 7 or more positive nodes, N2B. The number of involved lymph nodes demonstrates a dose-response relationship with prognosis, meaning that increasing nodal involvement correlates with worsening outcomes. Additionally, the ratio of positive nodes to total nodes examined provides prognostic information, with higher ratios suggesting more aggressive biology. Metastasis, M, component and distant spread. The presence or absence of distant metastases fundamentally influences staging assignment and treatment strategy. M0 designation indicates no evidence of distant metastatic disease based on available imaging and clinical evaluation. M1 classification identifies confirmed distant metastases, further subdivided based on location and extent. M1A encompasses metastases to a single organ system, such as liver-only or lung-only disease. M1B indicates metastases to multiple organ sites or peritoneal involvement, representing more advanced disease burden. M1C specifically designates peritoneal metastases, recognized as a particularly challenging form of dissemination. The distinction between these subcategories carries significant therapeutic implications, as some patients with limited metastatic disease may benefit from surgical resection of both the primary tumor and metastatic lesions. Stage grouping and clinical significance. The individual TNM components combine to produce an overall stage designation from stage I through stage 4. Stage I represents early stage disease with limited local invasion, T1, T2, and no regional nodal involvement or distant metastases. Stage 2 encompasses more locally advanced tumors without lymph node involvement, including T3, T4 lesions confined to regional extent. Stage 3 includes any tumors with regional lymph node metastases regardless of T classification, representing the involvement of the lymphatic system. Stage 4 represents the most advanced category, characterized by the presence of distant metastatic disease. This staging framework allows oncologists to group patients with similar disease characteristics and expected outcomes, facilitating treatment planning and prognostic counseling. Patients within identical stages generally experience similar survival trajectories, though individual variation exists based on other factors. Pathological staging and specimen evaluation. Following surgical resection, pathologists examine the resected tissue specimen to assign definitive pathological staging. The surgeon's extent of resection directly impacts staging accuracy, as adequate lymph node sampling requires removal of sufficient regional nodes. Current guidelines recommend examining at least 12 regional lymph nodes to accurately assign N classification, though this target is not always achieved in clinical practice. Pathologists assess the depth of tumor invasion through the intestinal wall layers, evaluate for lymphatic and vascular invasion, and count all involved and uninvolved lymph nodes. The number of negative nodes examined provides valuable prognostic information independent of the number of positive nodes. High-quality pathological assessment, including proper specimen orientation and thorough tissue sampling, ensures accurate staging and guides subsequent adjuvant therapy decisions. When specimen examination falls short of recommended standards, the staging accuracy may be compromised, potentially leading to inappropriate treatment recommendations. Clinical staging and preoperative assessment. Before surgical intervention, clinicians perform clinical staging to estimate disease extent and plan the surgical approach. Colonoscopy with tissue biopsy confirms the malignant diagnosis and evaluates local tumor characteristics. Cross-sectional imaging, including computed tomography of the chest, abdomen, and pelvis, helps identify distant metastases and assess local extent. Magnetic resonance imaging provides superior soft tissue characterization in some situations. Positron emission tomography scanning may identify distant metastases in selected cases. Endoscopic ultrasound can evaluate the depth of wall invasion and regional lymph nodes in rectal cancers. Clinical staging provides an estimate of TNM classification before pathological examination, informing initial surgical planning and determining whether palliative or curative intent approaches should be pursued. However, clinical staging often underestimates disease extent compared to final pathological staging, as microscopic spread cannot be detected by imaging modalities. Treatment decision-making based on stage. Colon cancer stage directly determines the recommended treatment approach and intensity of systemic therapy. Stage I cancers typically undergo surgery alone, with colonoscopic polypectomy for selected small lesions or segmental colectomy for larger tumors. Stage 2 and 3 cancers generally require both surgery and adjuvant chemotherapy, as these stages carry significant recurrence risk. The specific chemotherapy regimen varies based on clinical factors, patient age, and performance status, but fluorouracil-based regimens represent standard therapy. Stage 4 disease management depends on the extent and location of metastases, with some patients being candidates for surgical resection of both primary and metastatic disease while others require palliative systemic chemotherapy. The stage assignment allows patients and physicians to engage in informed discussions regarding prognosis, treatment burden, and expected outcomes. Progressive stages correlate with diminishing 5-year survival rates, though individual outcomes vary substantially based on response to treatment and other biological factors. Grade and molecular factors beyond staging. While TNM staging provides a robust framework for disease assessment, additional pathological and molecular characteristics contribute important prognostic information. Histological grade, assessed by examining cellular differentiation patterns, correlates with prognosis and treatment response. Well-differentiated tumors generally carry better prognosis than poorly differentiated lesions. Microsatellite instability and mismatch repair status provide insights into treatment sensitivity and prognosis. Tumors with high microsatellite instability may benefit from specific chemotherapy combinations and demonstrate different recurrence patterns. BRAF and KRAS mutations carry prognostic significance, particularly in metastatic disease. Lymphovascular invasion, identified on microscopic examination, indicates higher risk of systemic dissemination. These factors function as complementary information to TNM staging rather than replacement, refining prognosis and potentially guiding therapy selection in specific clinical contexts. Prognostic implications and survival outcomes. The strong correlation between TNM stage and patient survival provides the fundamental rationale for standardized staging systems. Stage I colon cancers demonstrate 5-year survival rates exceeding 90% in many series, reflecting the excellent outcomes achievable with surgical resection alone. Stage II cancers show more variable outcomes, with 5-year survival rates typically ranging from 60 to 85% depending on high-risk features and treatment receipt. Stage III cancers, despite more advanced local disease, often achieve 5-year survival rates of 50 to 75% with appropriate surgical and adjuvant chemotherapy. Stage IV cancers carry substantially worse prognosis, with median survival measured in months rather than years in the absence of metastasectomy or effective systemic therapy, though palliative chemotherapy extends survival compared to supportive care alone. These population-level statistics must be individualized for each patient based on age, comorbidities, treatment tolerance, and response assessment during therapy. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.